Thank you very much, Nino, and thank you, Jean-Louis Vincent, for this invitation, of course. And I'm very happy to present the neurological examination of a comatose patient. I will present it in a traditional way, but it is since now 100 years of neurology. It has not changed a lot, in fact. As you know, the coma is the most important cause of admission in ICU, ranging from 25 to 60% of ICU patients. It is the leading predictors of death, length of mechanical ventilation, and level of stay, of course, in ICU, and is the evaluation of coma is integrated in most scoring systems of critical illness severity. And as you can see on this slide, that coma is far the most important cause of death, with an odds ratio about 20 in comparison to age or the presence of shock. So what is coma? It is a clinical definition, and it is characterized by the association of an alteration of wakefulness or absence of arousal, which is featured by lack of eyes opening and absence of sleep-wake cycles, and also an alteration of awareness or consciousness. So the patient is not aware of himself and of the environment. Comatose patients are not sleeping. Comatose patients do not speak, do not move spontaneously, and do not follow commands. And when provoked by a noxious stimulus, their eyes remain closed. Vocalization is limited or often absent, and motor activity is absent or abnormal and reflexive, rather than purposeful and defensive. And you know that a major diagnostic differential is a non-organic cause of alteration of consciousness, and in non-organic cause there is a presence of avoidance, so the patient is blinking to freight, and you do not let, for instance, his the hand fall on his face when we put his hand upon his face. And if you have any doubt for an organic cause, do an electroencephalogram. But I will go back to this point later on in my presentation. Of course, there are different types of alteration or disorder of consciousness. So, according to the combination of absence of arousal and absence of awareness. For instance, as I said just now, coma is characterized by the absence of arousal and awareness. The vegetative state is characterized by the presence of arousal. The patient is awake, and sleep cycles are sleep cycles are preserved, but there is an alteration of consciousness. Minimal consciousness is characterized by also the presence of arousal and alteration, mild alteration of awareness. And of course, for instance, Lockheed syndrome is characterized by the preservation of arousal and awareness. This has been well presented in this table by Robert D. Stevens in Critical Care Medicine in 2006, and I won't present all this table, but as you can see, EEG can be helpful to discriminate these different type of disorders of consciousness, ranging from brain death to Lockheed syndrome, which is not a disorder of consciousness. So, alteration of awareness is related to an abnormal structural abnormalities or functional abnormalities of these three pathways: a dorsal pathways, a ventral pathway, and there is also a third pathway involved in awareness. And as you know, that these pathways involve the activating reticular ascending system. It involves also the hypothalamus and the basal forebrain, and also the thalamus. Coma can be due to different type of lesions, and especially it can be related to diffuse hemispheric lesions, as shown here, or a diencephalic lesion, or a mesoencephalic lesion, or of a pons. And this has been well described in the very famous book written by Plum and Posner. So there is a simple definition, of course, of coma, and everybody knows this Glasgow coma scale, which enables to assess the motor response, the verbal response, and the eyes response, and a score less than 8 define coma, when it is characterized by a motor response less than 4 and a verbal response less than 2 and an eyes response less than 2. So why should we do a neurological examination of a comatose patient? Of course, it is very helpful for the diagnosis and to make the diagnosis of coma, because it's a clinical, coma is clinically defined, to assess its severity, to assess its cause, and also its prognosis. So, as I just say, when you're doing a neurological examination of comatose patient, you have to assess the eyes response, the motor response, and also the verbal response. You have to seek for the focal signs, to seek whether there is or not myoclonus, and to assess all the brainstem responses, including eye spontaneous movement, eye position, oculocephalogy response, sometimes the oculovestibular response or caloric response, the pupillar size, the pupillar light reflex, the corneal reflex, the grimace, the cough reflex, sometimes the oculocardiac response, and of course to assess the respiratory pattern. This neurological examination takes about 10 minutes. So you know all the motor response that you can elicit by a noxious stimulus. You know, you can see some focal neurological sign here with a Babinski, an external rotation of the lower limbs. You can elicit a decortication movement or a decerebration movement. Looking at the eyes is quite important. Most of the time the patient have fixed eyes, but you can see conjugate deviation of the eyes, which is most of the time related to a lesion of the brain. You can see upward gaze, which is related to a bilateral hemispheric lesions, or a downward gaze, which most of the time is related to a mesencephalic lesion. And sometimes, and especially in sedated patients, you can see this type of skew deviation that can be related to an alteration of the Cajal nuclei. Movement, most of the time the patient has not, comatose patient have no spontaneous eye movement, but you can sometimes see horizontal or vertical movement, and most of the time, according to their velocity, their speed, they are related to bihemispheric or cerebellar lesions. The most famous is maybe the bobbing, which is related to a mesencephalic or a pons lesions. Pupils, you know that pupils, you have to look at the size of the pupils, and it can range from miosis to mydriasis. And everybody knows what means this unilateral areflexic or an areactive or non-responsive pupil. So these abnormalities can be, according to the type of, or to the of pupil abnormalities, you can spot where is the brain lesions. You know this sign. This is very important neurological signs, which is called the Claude-Bernard signs, which is characterized by an anophthalmia, a miosis, and a ptosis, and it can be related. It is related to an abnormality or lesion of the sympathetic nerves that controls the pupillar reflex, and it can be related because you know the pathway of these sympathetic loops, and it can be related to brainstem lesions, and especially in the Wallenberg syndromes, it can be related to spine lesions or to a lesion of the lung, of the upper part of the lung, and also it can be related to a carotid dissection, or where you're putting a catheter in a patient, you can induce a Claude-Bernard sign. This is a very important neurological sign. But let's go back to the oculomotor nerves. You know these signs. This is the third nerve palsy, characterized by a deviation of the eyes, by a mydriasis, and an absence of pupillar light reflex. And this is a very important neurological sign, and it can be, as you know, related to an aneurysm of the internal carotid. It can be related to a cavernous sinus thrombosis, and of course to a non-call herniation. Herniation, you know that it's an emergency in comatose patients, and there are different types. I'm sorry, it's in French, and it can be related to there are different types of herniation. Temporal herniation that is characterized by an by a unilateral mydriasis, and also an herniation of the occipital herniation, which is very also dangerous. It can lead to death very quickly because it alters or affects very quickly the centers or the respiratory centers of the medulla. So this is the sixth nerve palsy, which is very common, especially in patients with intracranial hypertension, and it has no localization value. Of course, you can do a phonoscopy in comatose patient in order to assess if there is or not papillary edema, which is a good sign of intracranial hypertension, but we do not value this routinely in fact. I told you about the oculocephalogic response that can be also completed by an assessment of a caloric response, and it enables to assess the reflexive oculomotricity. And so the normal response is depicted here. So when you're turning the head, the eyes going on the opposite way of the head rotation, and sometimes you can see either an alteration, absence of oculocephalogic response, or sometimes a disconjugation or disconjugate response. And this disconjugate response is related to an internuclear ophthalmoplegia. This is well depicted here. The patient, for instance, this is a conscious patient. The patient can move his eyes on the left direction. He can move his right eyes on the right direction, but he cannot move his left eye on the right direction. You can think that there is a third nerve palsy, but when you ask him to converge, he can move his left eyes on the right direction. This is an internuclear ophthalmoplegia and is related to an alteration of the posterior bandlet. Of course, you have to look at the respiratory pattern. And this is the most famous pattern, which is the chain-stalk pattern that is related to a diencephalic lesions, but it can be seen, of course, in other in patients with very severe cardiac insufficiency. You can see hyperventilation, apnea, which is related to brainstem lesions, and of course the gasp, which is related to alteration or lesion of the medulla. Cough reflex is very important, and you have to assess this when the patient is intubated, and you can do also an oculocardiac you can assess the oculocardiac response, but take care because it can induce a very severe bradycardia. It's better to do it. We do this when in patient to assess whether or not the patient is brain dead, but we do not do it routinely. So there are other respiratory signs that are very that can be seen and then can have a value for localization, yawning, hiccup, and also vomiting. You have to assess also the vital signs, the blood pressure and the respiratory and the heart rate, and also the temperature. It can be very important for to see the consequence of coma in the respiratory system and in the cardiovascular system, but it can help you to seek particular causes, and so this is a very, you can, in this slide, is summarize the relationship, the anatomical relationship between the different response, the motor response, the brainstem response, the pupillar response to light, and the breathing pattern according to the site of a lesion. I will go very quickly through these slides. I think that you will have the slides at the end of the conference, so I won't present all this because it's quite complicated, but there is quite, this has been well presented or assessed in the book also of Plum and Posner. So there are different scores, and the most used score is, of course, the Glasgow Coma scale. But I think that the score developed by Vizdik is quite interesting. You know, the main criticisms done to the Glasgow Coma Scale is that it doesn't assess the brainstem reflex, which is considered very important in the neurological examination of comatose patient because it can help you to localize the lesion and it can have also a prognosis value. And I think that the 4 Coma scale is good because it assesses as the Glasgow Coma scale the eyes response and the motor response, but it assesses the brainstem reflex and the respiration, and especially in patients who are intubated. And it has been shown that this fourth score helps you to distinguish patient with low Glasgow Coma scale. So it's a very nice score. So it is in this slide you can see how to assess the different response, the eyes response, the motor response, the brainstem reflex, which are essentially the pupillar light reflex and the corneal reflex, and also the respiratory pattern. So, of course, after having done a neurological assessment of a comatose patient, you have to conclude and to decide if not you will do an imaging, or if you'll do an EEG, or if you do a CSF analysis. So in all comatose patients, you have to assess, of course, the glycemia. This is routine. You have to know the medical history of a patient and the circumstances of a coma. This is very important in the clinical management of a comatose patient. You have to know whether or not there is a fever, neck stiffness. It's not very common for a comatose patient. Focal signs, if there is any doubt about seizure, and if you are in traumatic if there is a trauma. And then according to these signs, you will decide or not if you will do an imaging or a CSF analysis or an EEG. So let's do some clinics. I think that I have few minutes. 1, 2, 2. So this is a 78-year-old woman with hypertension and diabetes treated by anticoagulant for an atrial fibrillation, was referred to our ICU for a coma. Neurological examination showed Glasgow Coma Scale at 7, miosis, generalized hypotonia, and a bilateral Babinski sign. Biological screening is normal, and the frontobotic time is about 49%. What do you see on the CT scan? Here, yeah. Vitalomic, it was related to a stroke, and don't forget that sometimes even, stroke can be a cause of coma without.
You went so fast. Can you return and show it slowly for everybody to make sure?
Here and here you see the double hypodensity, spontaneous hypodensity. Hypodensities related to stroke, because this patient was not well anticoagulated, so she had a stroke. And so just to remind you that, comatose can be due to a stroke, and this stroke cannot always be associated with a focal neurological signs. Electroencephalogram is very important, but I think that Mauro Odo will talk about it later. But if you have any doubt about the organicity of the coma, do an EEG. And of course, sometimes it can help you for making the diagnosis, the etiological diagnosis. For instance, when it shows triphasic waves, it is very evocative of the hepatic failure. I will go through this very quickly. And about outcome, it has been recently shown that some brainstem responses have a high prognosis value, like the absence of pupillar reflex or the absence of oculovestibular response at day 0 of comatose, so at time of admission. And at day 3, you can see that pupillar light reflex and oculocephalic response has still some prognosis value. So, but it depends, of course, on the etiology, and for instance, absence of corneal reflex and absence of pupillar light reflex and absence of motor response have a great prognosis value at day 3 in patients with who suffer from who remain comatose after a cardiac arrest. My conclusion is very important to do a neurological examination. It takes only 10 minutes, and you have to assess whether or not the patient is comatose. If you have any doubt, do an EEG. You have to assess all the brainstem reflexes. You have to see whether or not there is a focal neurological signs. And according to your neurological examination, you have to decide or not. You will do an imaging, you will do an EEG, or you will do a CSF analysis. That's my conclusion.